Good afternoon, everybody, and thanks for the invitation to give you an overview about the clinical aspect of Fahr disease. So what's Fahr disease? Fahr disease is a rare genetic and neuropsychiatric disorder, which is characterized by bilateral symmetrical progressive calcifications in certain areas of the brain, including the basal ganglia, thalamus, cerebellum, and subcortical white matter. Initially, the disorder was named after Carl Theodor Fahr, a German pathologist who first reported a patient with epilepsy and diffuse brain calcification in 1930. And today, the term Fahr disease has been let's say, substituted in the recent medical literature by the new denomination primary familial brain calcification. I want to underline with you some of the keywords of this brief overview. So first, rare. How rare is Fahr disease? Fahr disease in number, the prevalence or the frequency of this disorder in the general population was thought to be less than 1 per 1 million people, but the minimal prevalence rate is now estimated to be between 2 and 6.6 per 1,000 people in the general population. The age of onset is in the range of 6 to late 70s or early second decade, early 9th decade. And the male to female sex ratio is 1 to 2, with the male having more severity in terms of brain calcification, especially for one of the genes discovered to be associated with this disorder. Male have also a higher chance of being diagnosed, detected with abnormal calcification early in life. The second keyword is genetic. So this disorder is familial. And as you can see here, is most commonly found to be inherited in an autosomal dominant pattern. What does it mean? It means that one copy of the mutated gene from one parent or a de novo event, which means a new mutation occurring in the patient for the first time, can cause the genetic condition. More recently, the same disorder has been associated with a couple of genes with an autosomal recessive trait, which means that 2 copies of the mutated gene, one from each parent, can cause the genetic condition. You can see here 6 genes which have been linked to Fahr disease so far. 4 of them, the first 4, as you can see, are inherited in a dominant mode, and they account overall for around 55% of cases reported so far. Major, which is a more recent gene, needs 2 mutated copies. It's a recessive and accounts for around 12% of cases. So overall, you can see that around 1/3 of cases is still pending from a molecular perspective. So we don't know exactly the genetic defect. And this might be due to the fact that there are still unknown genes associated with Fahr disease, or that we have limitations with the current genetic testing. I can show you here a few of the genes, the one which has been better characterized. So SLC20A2 and XPR1 are 2 genes, the first one encoding a transporter of organic phosphate in the brain. And loss of function of this gene is the probable mechanism causing Fahr disease. The second gene is XPR1, which encodes a transmembrane protein, again mediating phosphate transport. But in this case, the efflux, so the transport of phosphate from the intracellular setting to the extracellular setting, again in the brain. These are other two genes associated with autosomal dominant Fahr, PDGFB, which encodes platelet-derived growth factor beta and its receptor. And both these genes together cooperates in maintaining the integrity of the blood-brain barrier, so the interface between brain cells and blood. The two most recently discovered genes are MyOrg and GEM2. As I mentioned, these two are recessive, so this means that you need two defective copies of the gene to possibly develop the disorder. So this is the main difference compared to the previous one I mentioned. And I want to focus now on the mechanisms leading to calcifications in the brain. So by knowing the genes, we know first that from a pathological perspective, the hallmark of Fahr disease is the deposition of hydroxyapatite crystals in the basal ganglia and other brain regions. And there are, when looking at the mechanism of genes, and so at the genetic defects producing calcification, we know that these mainly account for two mechanisms of disease. One is the disruption of the calcium phosphate homeostasis, and the other one is the perturbation of the integrity of the blood-brain barrier. And these two mechanisms overall might contribute to the deposition of these calcium crystals in the brain. I will leave the rest of the overview, so the clinical manifestation and how we arrange investigation for the diagnosis with my colleague, Dr. Butler.
Thank you, Francesca. I'll just share my screen.